Oh, well, they're never moving fast enough, of course, but yeah, good, yeah.
No, it's, we have listened to
You'll see, one of our slides goes up. I mean, 85% of our donors are women, so I'm so used to walking in and seeing, 4 out of 5 faces.
Check.
Anyway, duly noted. The nice thing is, at least as the world's progressed, there are more women that actually have power, authority, influence, money.
Yeah, that's
so it's
especially
not
in the
just
US,
sort of a girls' club thing. It's not kind of a hand-wringing thing. There's actually,
Yes, that's definitely more of a US phenomenon, though, than I don't think it's more.
Things are moving forward fairly well. Circulating through the UNFPA system, we're mobilising a lot of people to come from all the countries. I don't know about numbers.
Hi, how are you? Good to see you. How are you? Yeah, I can't wait to see you.
hello, Ellen, nice to see you again.
Hi, nice to see you too.
Yeah. Hi, Mary.
Hello, Jillian. How are you? Just had to say hello.
Yeah, nice to see you. So that's twice in 1 week we met.
That's right. That's right.
As well at the breakfast meeting.
That's right. We're almost on the same trajectory.
It was really good.
It was really good.
When you get a chance. You're not in tomorrow, or are you in tomorrow? Okay, I will be in about 10. And then I'll
Move all my clutter here.
So if Laurie doesn't make it, you'll deliver her address.
I don't think so.
Okay, it's just a... Hi, Holly. Where?
trapped here.
Hi. I'm doing fine. When did you get back? And what are you
Wow.
doing? Yeah. Yeah. Are you living here in DC? Did you have a good time though? Did you love it? Yeah. That's so great. I'm good, yeah. They're getting a bit empty around into halfway. We're talking about it all the time. Bye. I must get distance glasses. I actually can't see anybody anymore.
Oh,
But the problem is when you can't see forward and you can't see the writing either. To
I was
get the
talking
very
to my sister did.
Yeah.
Same sort of thing. She's got one contact that's
Yeah,
this
that-
and one contact
yeah.
to that. I was talking to somebody yesterday in New York too. Same thing, where you train your eyes.
Did she wear contact lenses
She didn't
before?
No, she didn't. She's sort of like me, basically good eyes, perfect vision until 40 something.
Yeah, me too.
Yeah, me
And
too.
then
What a
this starts
handicap.
going, and then frankly,
Yeah.
50 something.
Yeah.
But then the distance starts
I know.
going.
It's always been vaginal reading. Now it's,
Yeah.
I can't actually, and now my distance vision is going as well, which is so annoying.
It
And that my
is.
ophthalmologist said to do that, and I thought, but I've never worn contact lenses.
Yeah,
I don't know how to get on with them.
I tried it a year ago for a week. I went in for just my eye appointment, and I said, "Oh, I want to try this." He said, "Okay, fine. We'll give you these test pair or whatever." And it's really good. It lasts until the practice pair I managed to rip, and then I just it's a great idea, but back to my this one. It's a meeting this week, and I think it starts going downhill fast because I was trying to look at a stage. And I realized it wasn't that I was seeing double, but everything was just
No,
blurry.
that's exactly
And I was
for
like,
me.
I hate this. I mean, even when I put these on, then it was still blurry. And
But I'm using my reading glasses slightly for distance.
So I am.
And then I got some distance lenses put in because in low light in a theatre I just can't see anything. But I kept thinking, I must be a bit tired because everything's a bit blurry, but obviously it's not.
Yeah, and
Sorry to interrupt you, but my English culture is not very good. What is a Kirkus review book? What is Herr Kirkus?
Kirkus, for Kirkus Reviewed. Kirkus is I think it's a book distributor. I mean, Kirkus Review, it's a kind of, you could just say a Kirkus Reviewed book. It means that it's not like some blog published thing.
Ah, it's brilliant.
No, it's not. It's
not.
It's not. It's not. The fact that it was reviewed by Kirkus means that it's not.
A bona fide
Somebody,
book.
somebody actually read it who reads books for a living, if you know what I mean.
So critically acclaimed.
Well, yeah, not quite that, but it's.
Critically what?
Don't say anything, just say book, a book.
You can say no, just say it the way she wants it, just because she's very exacting. If I were
Oh,
you, I would
yes,
say exactly.
that's
The
glorious.
people have
Have it? Oh, they do. Oh, okay.
How are you?
So that's
Yeah, nice to see you too.
Yeah.
Talking about.
Yeah, yeah.
Oh, right, yes, okay.
Yeah.
All right, but maybe it won't be clear to anybody else who's in the room, right?
That's Laurie, just arrived. That's Laurie. Yeah, she's
That was
just come
Laurie.
out.
Oh, no, no.
Oh, wow. Okay. That's not right. There she is.
Yes.
Well,
You need
done,
one
girl.
comedian on the panel, right? I walk in, everyone starts laughing. That's a good sign. How are you?
Where are you? You're here?
Good.
Yes.
Yeah.
Namaste.
Which works at all hours of the day and night, right? I thought it was good morning. Like, no, 3 o'clock in the morning. How would I know that?
Beautiful.
Are you straight from the airport? Almost. Almost. I miss
Mrs. Paul, you picked up some guy's thing. I'm kidding you.
I know. Because I need him, so I keep it right there.
Oh, is that what it is?
"Paul, this damn-" I think I bought a lemon. It's constant. Right? That's why I just left it there.
When did you arrive back?
Yesterday.
Wow, that's
yeah.
a
From the
long
pub.
way.
Yes, and I've got things for you in my bag.
Oh, merci. I must not forget him. Thanks so much for doing the control tower.
So why don't we begin today's program entitled Preventing Injuries During Childbirth, Programmatic and Policy Recommendations for Addressing Obstetric Fistula and Uterine Prolapse. My name is Sandeep Bathala, and I'm the Senior Program Associate with the Wilson Center's Global Health Initiative. Our Advancing Dialogue on Maternal Health series started in 2009, and today's event is brought to you today through the generous support of the United Nations Population Fund and the Maternal Health Task Force. I do want to encourage folks to move up so that those that arrive a bit later than the rest of you can get around easier, and then you can be a little closer to our wonderful speakers as well. I did want to make a quick note about the Wilson Center. I know that many of you have probably been here before. You probably have this memorized at this point, but the Wilson Center is a formal memorial to our 28th president. He was the only president thus far to have achieved a PhD. And here at the Wilson Center, we aim to bring the worlds of policy, program, and academia together so that we can gain a better understanding from each other. I am now going to actually direct your attention to our moderator, Luc de Bernis. He's the Senior Maternal Health Advisor with the Technical Division at the United Nations Population Fund. Thank you.
Thank you very much. And welcome. I think it's... yeah, I should use the mic. And this is a rule, we need to use the mic because this session is video tapped. So please, when we will talk later, all together, we will have to use the mic systematically. I'm very pleased to be here, and I would like first of all to thank the Woodrow Wilson Center. It's a long collaboration that we have, and we will continue certainly because I think it's very important for us. I'm talking about the Maternal Health Task Force and also the UNFPA we are representing here. I would like also to thank very much my friend and colleague Sarah Craven because she has proposed to have this panel discussion today, and I think it's tackling an issue that it's so important for all of us and also close to our heart. It's not only a medical issue, it's a human issue. And I think this will be very much apparent through the different presentations that we will have. So I'm very pleased to have this panel with a high-level expert, I would say, in the field of fistula, and representing the different, I would say, component or prong of any program that should be put in place to address a complex issue, and we will also see the complexity of what should be done to address that. I hope that we will have a good discussion, and all ideas and are very important for us to see how we can really be more effective, and also making fistula and other disorder, because we will talk about fistula, but also other pelvic floor disorder, maternal morbidity, or female morbidity. And we have to see how we should integrate, how we should put these issues really embedded in other programs, particularly women's health program and maternal and newborn health program. And this is, for all of us, a critical thing to be discussed. So we are very pleased to have you in the room, and we hope to have a very fruitful discussion at the end. The first speaker is my dear colleague, Jillian Slinger. She's a nurse midwife. She has worked a number of years in Swiss, and then she decided to work for MSF, Médecins Sans Frontières Suisse. And with MSF, she has been able to work in a number of developing countries, particularly in the Francophone world, in DRC, in Chad. But you have all the bios with you, so I will just summarize. And then she has been appointed as a sexual reproductive health advisor for MSF in Geneva, until the time she has been recruited by UNFPA, and she is now the special advisor of all our country offices in terms of fistula programs. But she is also, and this is very important, the coordinator of the global campaign to end fistula, because UNFPA has a duty to have the secretariat of this campaign. So Jillian has these two hats, and she's working for this. So Jillian, you have the floor. Thank you.
Good afternoon, everybody. It's a great pleasure to be here, and I'm highly delighted at everybody for pulling the efforts together to get this important panel and this session together, and I really look forward to the very good discussions. What I'd like to talk to you today about is the campaign to end fistula, progress, challenges, and the way forward. We're just trying to find the presentation. If we can have it on full screen, that would be better. That's okay. Okay, thanks. And as my colleague Luc has just mentioned, I think it's important to remember that when we work on obstetric fistula, although some of the approaches are considered quite vertical, really it is a key entry point to broader maternal and newborn health. And before I really move into my slides, I would just like to remind us all that maternal morbidity is a broad term referring to any physical or mental illness or disability directly relating to pregnancy and or childbirth, not necessarily life-threatening in itself, but which brings significant consequences and impact onto the quality of life of those who suffer maternal morbidities. I would like to ask, does everybody know what obstetric fistula is? Does anybody not know what obstetric fistula is? Yeah, I can see a few hands. Okay. Okay, so obstetric fistula is a condition which has largely been eradicated from many of the parts of the world, like in the States, Europe, Australia, America, Canada. Everywhere in the world, obstetric fistula existed more than a century ago. And sadly, it is still present in many poorer countries in parts of the world today. It has been eradicated with modern medicine, with skilled trained midwives, doctors, anaesthetics, and most of all, emergency C-section available to any woman who has a prolonged, obstructed, complicated labour. And they were the foundations which then eradicated fistula in many of these contexts. But it is a sad reminder of inequities, north-south inequities, and also within some of the of countries, inequities between regions, that really these embedded inequities, access to vital life-saving treatments, etc., they are not equally distributed. And so it is a very devastating childbirth injury simply caused by an extended period of labour simply because the baby is either too big to pass through the maternal pelvis, or else maybe the baby is lying in not quite the best presentation, the best position, and so the labour becomes obstructed. And what happens is that some of those pelvic organs, I think if you can see on the slide here, the red areas of the slide on the left, if you can imagine that with perhaps days and days of an obstructed labour, those areas are compressed. The blood supply is reduced to the areas and the tissue dies and it leaves a hole. And that is what an obstetric fistula is. It's a compression injury due to an unrelieved obstructed labour. So any woman in many contexts who does have an obstructed labour would automatically go for an emergency C-section before any of that tissue damage could occur. And once those holes have formed, the fistula, the obstetric fistula, the woman will be chronically incontinent for the rest of her life. Unless she has treatment. The other impact of an obstructed prolonged labour with the compression injury, not only the maternal organs and tissues are damaged, but also vital nerves controlling the legs. And on the photograph on the right, many of the women and girls, when they have a complex fistula injury, they suffer from something called foot drop. And they have like a paralyzed leg because the nerve has been damaged that controls the leg. And so they're immobile afterwards. And this condition brings huge stigma. I always talk about the traumatic transition from a happy expectant mother to a prolonged, nightmarish, terrible labour in which 94% of the babies die. The survivors with obstetric fistula, more than 90% of them will have a stillborn child. So to go from that happy expectant mother to an almost near-death experience during a prolonged labour without that life-saving C-section at the end, to have a stillborn baby at the end, and then once you're trying to recover from all of those series of events, you start to be incontinent. And with that brings often stigmatization, very bad odor. So many of these girls and women are social outcasts. They're not able to mix with their societies or their families. And what is important about it is that it is preventable, and in almost all cases it is treatable. So the goal of the campaign to end fistula is to help make fistula as rare in developing countries as it is in all other parts of the world. It was launched in 2003 by UNFPA and a small group of dedicated partners because fistula was deemed a seriously neglected public health and human rights issue. And it really reflects the inequities of health systems. And that obstetric fistula is really the condition that affects often the poorest, most marginalized women and girls in the world. We estimate that there are between 50 and 100,000 new cases of obstetric fistula in the world each year. The prevalence, there is no real consensus, but according to WHO, there are probably about 2 million existing cases of fistula in the world. And a key part of the campaign to end fistula has really been advocacy, to raise awareness about the condition through the media, and it has had a very big impact. And yet we feel that a lot of potential is still in front of us to really carry the advocacy forward so that it has an even greater impact. So the vision of the campaign to end fistula is that there should be no new cases of obstetric fistula, that existing cases should be successfully treated, all women and girls should be free of this devastating condition. Women who have been treated for fistula are reintegrated back into their societies from whence many of them were banished once they had the condition. And not only that they reintegrate successfully back with a productive life of dignity, but also that they are followed up very carefully in the future. That incurable and sadly some of the inoperable cases of fistula, that they should also be supported. And that the campaign to end fistula is based on what I call the 3 C's and the 3 P's strategy. And I know some of my friends will have heard me say this before. So that's communication, collaboration, and coordination. And partners, partners, partners. So the campaign to end fistula has significantly grown in its 9 years existence. It has quadrupled in size from really a handful of countries, and now it's present in more than 50 countries right across the world. And coming together at international level in annual meetings, there are 75 international organizations from many, many different backgrounds, medical institutions, academic institutions, NGOs, for example, Médecins Sans Frontières, Médecins du Monde, UNFPA, Engender Health, donors. We are very happy to have a new campaign to end fistula, World Vision, who has recently joined our efforts, and we hope that they're really going to work with the campaign to end fistula to roll out and accelerate the advocacy efforts to raise still more awareness about fistula. And when we think about fistula, I always like to remind an audience that wherever you have high obstetric fistula, you automatically have high maternal mortality, high newborn mortality and morbidity as well. The three are inseparable. And the survivors of obstetric fistula, they are the living proof of high maternal mortality. So the yellow countries in the map are where the campaign to end fistula is present. But there are countries with fistula beyond the map. For instance, we were recently averted by somebody in the Philippines of a case of obstetric fistula, and the power of partnerships of the campaign, this dynamic partnerships that all these dedicated agencies and partners working together, we were able to get help to that woman who has now had a successful fistula repair in the Philippines. So the three pillars of the campaign to end fistula, of all fistula work, is prevention, all the strategies that we're all aware of, skilled midwives, emergency obstetric care, many other issues, family planning, and also the campaign likes to make special attention to prevent any subsequent obstetric fistula from ever occurring to a woman or girl who has had successful treatment and is able to conceive again and have another pregnancy. So to prevent a subsequent fistula is indeed a challenge, but we also have brought more focus to that. With regards to treatment, surgical treatment can repair obstetric fistula, and there are high levels of success closing the fistula, and yet still challenging is to actually to give back a good continence mechanism. So closing the fistula is one issue, and actually re-establishing a continence mechanism is again still very challenging. And we have very, very limited expert fistula surgeons able to do this very, very complex surgery. Social reintegration and follow-up is the third pillar of fistula work. So that is helping the women, equipping them once they've been treated, or for the incurable, inoperable cases. It's preparing them to reintegrate back into their own societies, income-generating activities, etc., and to be able to, like I mentioned, to have a life of dignity. And the follow-up period, looking at, are they recovering if they've had treatment? Are they reintegrating successfully, or are they still being stigmatized even though they may have had successful surgery? And also to consider, how can we guarantee their survival in their future pregnancies if they've had a successful treatment, or if they go on to have another pregnancy in the future. Midwives are a key part of this dynamic, working of course very carefully on the prevention with use of the partogram, careful monitoring in labour, and also the early management of a fresh new fistula, which is a critical opportunity to also possibly do some care which prevents surgery at a later stage. And then of course midwives and other health workers are very important with identification of cases to make sure they are referred to an expert worker, to an expert surgeon. Looking at some of the recent progresses of the campaign to end fistula, and I won't go through them all, I'm aware of the time, there have been many new fistula wards and centres integrated into broader hospital contexts. And the two photographs that I've shown on the slide, that's a hospital in Angola, and also the National Reproductive Health and Fistula Repair Hospital in N'Djamena in Chad as well. And they're both two new services for fistula integrated within hospital contexts. UNFPA are in the preliminary discussions of looking at how we can work on two or three pilot countries, looking at how we might integrate fistula and pelvic floor, uterine prolapse activities a little bit more together. And this will be mentioned, I think, by some of the other panelists during the course of the discussion. Another success of the campaign to end fistula with partners is the production of the FIGO-led, with partners, the competency-based training manual for fistula surgeons. This is groundbreaking, setting standards for the training of fistula surgeons. Available in paper copies. I've just brought the CD with me. Also the use of fistula advocates, recovered women who have actually had an obstetric fistula, to then receive some training to help their sisters and their own communities to become advocates about the prevention and management of fistula, and also to move it beyond that, to become safe motherhood ambassadors for the improvement of maternal health. And also the United Nations Secretary General report on fistula, the third of the series, it's produced every 2 years, has just been compiled over the summer. It is, I think we do have a few copies here. And basically it's looking at the progress on prevention, treatment and social reintegration of fistula globally. And really the key findings from the latest SG report is that yes, progress has been made, but it is still drastically insufficient, and that fistula sadly remains a global injustice and a human rights violation, and intensification of efforts is needed. Another recent highlight of a nice dynamic of 3 campaign partners, Direct Relief International, Fistula Foundation and UNFPA. It's for the first time ever we were able to make a fistula care map across the globe. You can see the website address there. And that is really helping us to look at the gaps and to really more strategically and appropriately be able to steer our activities forward. And it's an ongoing exercise. We will be putting lots of new layers in the map to build on the evidence, and also to help things to move forward in the right direction. Some of the challenges, there are many, and I'm not going to go even through all those on the list. One of the key problems when we look at maternal morbidity and obstetric fistula as well is there is a serious lack of accurate data on prevalence, on incidence, and when we think about fistula, because of the very nature, the stigmatization of the victims, they remain hidden, they're ostracized, and it's very difficult to know exactly how many cases are in any given context. There is a severe shortage of funding and human resources to manage obstetric fistula. We're working hard with partners on changing that. Also a lack of fistula treatment services, expert surgeons, and this means that only a very small fraction of the women and girls get treated each year. With the Global Fistula Care Map, we have estimated with our first findings for 2010, only 14,000 repairs were provided worldwide. And when we think that there are up to 100,000 new cases every year without this estimated huge backlog for many, many years, which remains unaddressed. I mentioned already another challenge, the follow-up and tracking after fistula treatment to prevent a new fistula is also a great challenge. And still, despite all the advocacy efforts of the campaign to end fistula and all the partners in that dynamic, there is still a great lack of awareness globally about what the condition is. And I know that when people actually hear the devastating condition, how atrocious it is for the women and girls who suffer from it, they are shocked, they are moved, they are mobilized to help. And so we can all, I think, still do more advocacy to raise awareness about the condition. We need, looking forward, to scale up resources, financial and human resources, to have ongoing fistula services part of these hospital setups so that the services are integrated with the broader services. Ministry of Health, national task forces for fistula, bringing all the key partners within a national context around the table. tackling the root causes of fistula, the poverty, the inequalities that I talked about in one of my earlier slides, looking at gender issues, the vulnerability of adolescent girls, very important, challenging, to address all of those issues. And also to promote the work of fistula advocates. And on the photograph are two, it's Sarah and Nora, who are both from Kenya, with the Ministry of Health from Mozambique in the annual meeting of the Campaign to End Fistula Partner last year. And for the first time ever, they came into the annual meeting and actually sat alongside the experts to bring the perspectives of the survivors themselves into the meeting. And this is something which we will be continuing in the future. So just before I finish, this is my final slide. I wondered, can anybody tell me how old you think these girls are? These are girls in sub-Saharan Africa who both have obstetric fistula. They're malnourished, they both have foot drop, they both had a stillborn baby. Any offers as to how old you think they are?
15.
Yeah, they're both younger. The little girl on the left, that's Zaya, and she's 13. And Zikra, in blue on the right, she's 14. And they both had obstetric fistula in sub-Saharan Africa and all its terrible consequences. And to finish the presentation, I would like to thank you very much for your attention, and just to remind everybody that in a world of unequals, the most unequal of unequals are the women and girls with obstetric fistula. Thank you.
Thank you, Jillian. Thank you very much. It's always very difficult to summarize on 5 minutes a huge work which is ongoing. But you have all understood that from the beginning of this campaign 9 years ago, it was very clear for all that piecemeal efforts will never achieve anything seriously. And so it was very important to give to all partners interested, small or big NGOs and aid agencies, a platform where we can exchange ideas, when we can share good and innovative ways of addressing the issue, where we can also find good partners to complement what we are able to do ourselves, etc. And this is, I think, the beauty of this campaign, which will meet again in some weeks in Dhaka, Bangladesh. And I think thank you for this presentation, because you have tackled many, many issues, and this can come through the next presentation, but also during the discussion later on. It's a big pleasure for me to now introduce to you, if you don't know her already, Kate Grant. Kate, and you have the bio, so again I will be very short, but she has an impressive career. She has started after the university, a successful graduation in Berkeley. She has started as advertising executive, so in big companies in the US.
Mad Men plus 20 years more women, something like that.
Yeah, exactly. And you will immediately understand why she became a strong advocate of the cause of the woman living with fistula. She has had a very important position in USAID, in the House of Foreign Affairs, in the committee staff, and she has been the first chief executive of the Fistula Foundation, and this is the reason why she's here with us, and the reason why also we have the pleasure to know her and to work with her. So please, Kate, you have the floor. Thank you.
First, I wanted to thank Sarah Craven, because I don't think any of us would be in the room without Sarah's leadership. Right over here, Sarah. I think she actually appreciate it. And also UNFPA, just to echo what Luc said, they've played just an important strategic role. The role, I think, most of us hope a great multilateral agency like the UN will play, and you've been critical on fistula. Just as an aside, my first big UN meeting, and now I'm dating myself, was 18 years ago in Cairo. I was a new staffer up here, freshly minted Princeton degree, thinking I knew it all. Boy, did I have a lot to learn about that. And anyway, the meeting in Cairo addressed really the whole range of issues around women and development, population and development. It produced a 189-page plan of action, which is still kind of the the touchstone for the field. And what's interesting, in 189 pages that deals with male involvement in contraception, girls' education, what we called at that point female circumcision, a euphemism if there ever was one, you can do a word search on that 189 pages and you will not find the word fistula, which I think is fascinating given obviously this condition had been affecting women since women had been having babies. Before I went to this meeting in Cairo, I had gone, again, freshly admitted staff for Ethiopia. We were looking out at the USAID food aid program, which was considerable. I was traveling at that point with all men on a Codel, and they said, oh, well, Kate, you're into all those women's issues. Why don't you go to the fistula hospital? And none of them wanted to go. Okay, fine. I head over in a cab to go to the fistula hospital. Again, lack of awareness of this issue. And I just come out of a program where I really was focused on, in graduate school, demography. I'd even thought about staying to do a PhD until I realized I was too ADD for that career path. But I mean, that's what I was focused on. I'd done volunteer work in my AdGal life, done volunteer work for Planned Parenthood. So I really, there was some background. I head over to this hospital and I'm thinking, they were occupied for a while by the Italians. I mean, the Ethiopians were. And maybe there's a Mario fistula out there. I mean, that word did not mean anything to me. Now, to these guys, well, they're laughing because I'm the one without the medical background. And fistula is actually a generic medical term. You can have renal fistulas, anal fistulas, any place there's a hole between an internal organ and the outside world, that be a fistula. We're not the Obstetric Fistula Foundation, but technically we really should be because we only work on that. So I'm just giving you that because I heard a couple brave people over here say that they'd not, heard of fistula, they didn't know what it was. Well, the world didn't know what it was. I mean, women that have this condition definitely knew what it was, and some heroic providers, including Dr. Hamlin in Ethiopia that pioneered a hospital, sure knew what it was, but the world didn't know what it was. And even the smartest and most kind of with it policymakers, it wasn't on the agenda. So I give you that just as a bit of my own humility that I continue to trip on. What I wanted to do is start just with a quick story, because I like stories, back to my AdGal days. Just to think about an individual woman for a second. I mean, the big macro statistics are great, but if you think for a second about being a woman, and there's a lot of women in this room, so I don't have to push you a lot to think about being a girl, but picture yourself, you've just gotten married, within the last year, you're expecting your first child. You're really excited about that, but come on, gals. You start getting bigger, and you start thinking, how's that all going to happen? There's nervousness and excitement about it. But you picture you're someplace like that. What is that going to start feeling like? I'm excitement. There's probably a lady that's going to help you with birth. So let's picture there's a woman that's going to go into labor. She goes into labor about midnight. Now, first birth, labor's going to, these guys are the midwives, but 12 hours, 18 hours, that's not unusual. So she's in pretty, heavy active labor, 12 hours, night turns to day, day turns to night again. And the woman that's helping her deliver says, time to push. She's looking, there's a baby's head there, time to push. Hours of pushing, and that baby's not going anywhere because, to Jillian's point, that baby's head is too big, pelvis too small, and that's a pretty, unfortunately, too common position for women to be in places where they were malnourished as girl children, stunted pelvises. So you're in that hut. You're this woman. You're in that hut. What happens? What happens if there's no emergency obstetric care available? Chances are actually you don't get a fistula. Chances are probably better that, one, that your baby's going to die 90% of the time. But actually, worse things can happen. You can die. Your uterus ruptures. You end up with some horrible infection because you've got a great opening for bacteria to get in where that baby's head's not coming out. Anyway, bad endings. But I want to tell you about a quick happy ending, because the woman I'm talking about delivered here, which is New York, with the woman provider. The woman provider was actually a skilled OBGYN, and that woman would be me. And that was the child who's now a precocious, talking back 12-year-old boy. But anyway, I ended up with a C-section after 24 hours of pushing, and I'd gone to all those classes and held the ice cube. Now, why they have you hold ice cubes to try to replicate the pain of labor? I don't know who came up with that, but why bother? But anyway, it'll give you a sense, I think, of if the things that we all take for granted here. I'm not going to go through what is fistula, because this woman did a much better job than I do if I had all day. I'll leave this one up for a second, though, because I think if you're going to take away anything from this, is that fistula really is a symptom of a system that either doesn't exist or failed for women when they need it most. Labor is a very time-sensitive event. If you get yourself to, or somebody in your family after that 12 hours, 18 hours, 24 hours, 3 days of labor gets you to a health post and there's nobody there that can do a C-section or can somehow pull the baby out with forceps, you're in trouble. Let me just keep going on. So we view the fistula really as an orphan disease. Back to 18 years ago in Cairo, why was this not getting addressed? Well, we use a lower figure. We're conservative, even though we're crazy ad gal type people. We're conservative, and we think there's going to be. We've heard. I can't get my hands on it, but I've heard from reliable sources. There's some really good analysis that's coming out soon that will show a dramatic drop in the projected numbers of prevalence numbers for women with fistula, and that's actually good, and it shouldn't be surprising because, again, what would have happened to that woman in the hut if she hadn't ended up with a fistula? She would have maybe died worse. We've seen obviously these great drops in maternal mortality projections coming out of those wonderful quant jocks up at ICME, the Institute for Health Metrics, IHME, Institute for Health Metrics and Evaluation up in Seattle. Anyway, but that's still a lot of women to be incontinent outcasts. And here's a point that I will mention again and again and again because it drives what we do. Only about 1 in 25, and again, that's a really conservative estimate. It could be almost twice that if you take the literal numbers that we saw on our map, which was about 14,000, and you do the fast math. We've sort of said, well, maybe there's some underreporting of number of surgeries. It just means that there's a huge gap, even with the most conservative numbers around, and the number of women that are actually getting treatment that we know have this problem. Why, again, we talked about this. Why is that? Guess what? Where does the system fail? The poorest countries for the poorest women. Who are some of the least empowered? This is Jillian's last point. Who are the least empowered human beings on the planet? Illiterate, young, women in, developing countries. So our challenge, and I should say that, foundation sounds like Rockefeller Foundation, Gates Foundation, like there's some dead rich white guy that gave us money. No. I wish that were the case. If you know anybody that's planning on dying and want to leave some money, we'll take it. But we're actually the private sector response. We raise our money from donors in the US and Europe, and our challenge in order to do that is obviously to open the hearts and minds, get people thinking, get people feeling about something they didn't even know existed, and then get them to open their wallets. We are very focused, and I love that you went first because you gave such a great overview of the whole field. We are somewhat, it's not ruthless, we're just definitively focused on the treatment piece of it, which obviously is not the whole way to eradicate this thing at all. And that's why UNFPA's role is so important, working on prevention strategies, emergency obstetric care, family planning that we know helps couples plan and space children. The Fistula Foundation doesn't work on that. We fund surgeries. I kind of joke that we want to be the smile train of vaginas, and mostly because people already see those smile train pictures and they know what that is. Actually, fistula surgery is much more difficult in many cases than is a cleft palate surgery. And so, and the places where fistula surgeons work are tougher neighborhoods than where 70% of smile train surgeries are done, which is China and India and big cities. So actually the fistula ward it's a tougher challenge. But I say that mostly to say we, like smile train, are focused on the curative piece, realizing that there are no silver bullets in this field. If you can't tell, the reason this problem's been around for forever, is that there's sort of silver buckshot maybe, and we work on a piece of that. Now, it's about 85% women in here, isn't it? So it's about, even to our donor base. We didn't target women initially when we started, and we've gotten some wonderful press from Nick Kristof through the New York Times, which obviously, hits men as well as women, but 85% of our donors are women. For, understandable reasons. Again, look around the room. We started out funding in Ethiopia exclusively, and about 4 years ago we changed our mission and broadened it, and now are funding projects in 19 countries. Truth, though, in advertising, I shouldn't say advertising not known for being truthful. To have these things colored in, there's no way women and every woman in those countries are being covered. Those are just places where we have facilities that we're funding, but it would really, you'd walk away with a completely wrong impression if you thought those women are handled, because it just ain't the case, unfortunately. And back to, focus on treatment, we fund the sweet spot for us in terms of where money goes fast, quickly, without any friction, me, board, whatever, is patient treatment. So if you've got a respected surgeon where we've done the research on that facility and that person, and you've got a patient and you just need money to get them treated, you got us at hello. Money tends to move quickly. Again, with a proven provider, we do a lot of homework and research on who we send money to. Our biggest hedge against kind of the waste, fraud, and abuse that happens in places where you have governance structures that are weak is we do invitation-only grant making. We pick people we want to work with. And I mean, that's kind of, when we do site visits and reports and reference checks and all the rest of it, but the core of it really is know where you're sending the money. Jillian was mentioning this earlier. We could spend 2 hours talking about it. One of the biggest supply kind of chain problems as far as fistula treatment goes is this lack of trained surgeons, because since fistula was eradicated here, most US surgeons, pelvic floor, urologists, et cetera, and Lori could talk about this because she's the true expert, are not trained in this. And because it's, again, a trauma injury where it varies woman to woman, experience counts, and yet that's not experience Northern doctors are going to get. FIGO, as Jillian was mentioning, which is the French acronym for the International Federation of Gynecologists and Obstetricians. You could say it beautifully in French, but if I did, it would just be, people would laugh. So we won't do that. But anyway, they've stepped forward with a really quite exciting training program. USAID had helped fund it, UNFPA. We came in basically with money to fund fellows and to now fund somebody in London, which is going to run this multi-site training program. That's exciting because that'll get one of the bottlenecks out of the way. When needed, we help build capacity, but that's only if we've got somebody that's a proven surgeon, and it's usually not building a place from scratch. It's usually, you need new lights, you need a new table, you need to, trick out a room that's already there that just needs refurbishment. We do very little from scratch just because there's a lot of risk. There's a lot of blue chips associated with a capital investment in places where the toughest thing to find is the doctor, not actually build the facility. I mentioned this a bit in terms of our grantee process, but we really do try to work with our grantees as partners and think about investing in them and actually learning from them, because going back to that meeting, 18 years ago, this field is making itself up as we go along. I mean, the people at UNFPA are very much a learning organization, and we are too. And yet money can create a funny, imbalance of power. If we're writing the checks or wiring the funds, there's a tendency then to maybe not be as honest about things when they don't go as well. We want to keep those lines of communication open so that we can learn from people and they don't feel like they have to hide mistakes. I'm not sure how well that's going. I think maybe people still hide things, but we try to, create an environment where that doesn't happen. Our 80-20 rule, and that's probably more my private sector thing coming out, is that out of the money we raise, our bottom line, if you will, what we're aiming at the end of the year, is the net kind of profit. And that's the money that we have left over for our grants. Back to there being no dead, white guy that left us a lot of money. The money that we're raising, the name of the game with us, is how do we find the best people to give it to while spending the least amount of money on ourselves. And frankly, work that's done by USAID and Engender Health help us do that, because we can ride we can ride on them on some of the intellectual capital about on the field. Our results, I could go through this quickly about number of dollars and surgeries. Let me go through some charts, they're better. This is kind of our pitter patter of the last 5 years, and we've gone up by about a factor of 4 in terms of number of surgeries we're supporting. But that's just the beginning. We're hoping, and actually, I mean, I'm hoping we tend to be conservative about our estimates. We're expanding the number of sites we're going into and countries at the same time. This, what does this chart say? It's this, we're all in it together. We're never going to be able to go it alone, kind of any of us. We all have a specific role to play. We all are one sort of piece of that silver buckshot. And this one's doing a great job, and I am delighted to be here. So questions and answers at the end, or at least questions anyway. Thanks.
Thank you, Kate. Thank you very much. I think you also made some very, very good points, reminding us that we are talking about survivors. And these women are lucky in a way because they escaped from death, and they are talking as Jillian said before, as advocates, and they are talking on behalf of all these women, not only those surviving, but also those we died. And also the fact that the maternal mortality has decreased, and that probably and certainly the number of women with fistula is also decreasing. And this is also showing the need to really work on the prevention and on the treatment and reintegration at the same time, because we are all this is interdependent. And the fact that for the moment we are not able yet, probably, to treat all the women who come with a new fistula each year. So the backlog of women in needs is still enormous, and each year we are not able to treat all the new cases of fistula. This is the situation, and this is what is a challenge that we have. So thank you very much for all these points. The next speaker is my colleague Selia Pet, who is a midwife. A nurse midwife. She is from UK, so nobody is perfect. She is nurse midwife.
Thanks, Luc.
But she knows my humor, so it's fine. And Kate has worked in a number of countries in the world. She has also published a number of papers in midwifery issues. We worked together in some unfinished work recently, and she is now advisor in the engender health, especially working on fistula issues. And it's very important to have her here, because engender health is certainly one of the major partners of the campaign. She will talk about research, and we need desperately to have more research on the field of the fistula. So thank you, Celia. You have the floor.
Thank you, Luc, for that nice introduction, and it's great to see you all here. Yes, I'm a midwife, and I work on the Fistula Care Project for Engender Health. And we've been asked to speak about the feasibility of integrating programs for fistula and prolapse. I just want to give you a quick bit of background to Engender Health if you don't know us. We're an international NGO that works, our organisational focus is on helping women to meet their reproductive intentions. That means having the number of children they desire rather than the number that their circumstances might dictate. Fistula Care is a project that's funded by USAID, managed by Engender Health, and implemented with partners in more than 10 countries. We have 4 main activities. One is the provision, similar to Fistula Foundation. We try to provide high quality treatment and repair for fistula. We also focus on prevention by improving labour monitoring and access to emergency obstetric care. We gather data and do research to improve the evidence base and clinical practice. And we also try to support the enabling environment to provide good quality fistula services. Sorry, I have to wear my glasses. So, what is Fistula Care's interest in uterine prolapse? Does everybody know what uterine prolapse is, or should I also explain that briefly? Briefly? Explain. Okay. Uterine prolapse is more accurately described as pelvic organ prolapse. It's common in rich nations as well as developing countries. In developing countries where it remains a major problem, it's usually caused by having too many babies too quickly together, so not good birth spacing. And also undernutrition plays a part because it reduces the strength of the tissues. So what happens eventually is that the pelvic organs, primarily the uterus and the bladder, fall down, which causes a lot of discomfort, and eventually the uterus may actually fall out of the body, and you can imagine the problems that causes. So it is a major problem in developing countries. What we've done, because we, in our work and over the lifespan of the project, which is started in 2004, we see a lot of reproductive morbidities, and we've been asked to look at how we could address these morbidities. So we've done ongoing data collection on prolapse and other morbidities at our supported sites, for example, in Ethiopia, Bangladesh, and Nigeria. And to follow this up, we developed a concept paper on the feasibility or programming considerations for integrating prolapse and fistula services. And in 2012, I did an exploratory visit to Nepal, where I used to live for 2 years before we moved to New York. So I'm relatively familiar with it and love it. And Nepal was chosen because it supposedly has the highest global prevalence of uterine prolapse. And also obstetric fistula is just hitting the radar there as an emerging problem. And for future work, we're planning community screening in Nigeria to look at what the comparative prevalence is for planning programming. So now I'm just going to move on to looking at some of the opportunities and challenges for integrating services. I took this photo from a street mural in Kathmandu, which is an advocacy mural for prevention of uterine prolapse, as in don't carry lots of heavy firewood and have so many children. And so the opportunities, well, clearly there's a strong case to be made for approaching reproductive morbidity in an integrated fashion. There's the rights-based perspective, and potentially it could be very cost-effective and more sustainable. I'd like to give an example from Nepal, because Nepal actually was very progressive. They've always taken a reproductive rights-based approach to morbidity, and in 2006 there was a constitutional mandate for universal access to reproductive health. But they have, in the context of a relatively fragile health system, particularly in terms of skilled human resources, they found it difficult to translate the rhetoric into reality. Going on to the second point, strategic advantages for advocacy and prevention. Well, there are obvious overlaps between the direct and the indirect causes of prolapse and fistula. They are, as Jillian has pointed out, they are lack of access to emergency obstetric care and skilled attendants, and also the social determinants of maternal ill health, which are poverty, lack of education, that sort of thing. So there are advantages there to approaching it in an integrated way. And another example from Nepal, which could be extended to include fistula, in Nepal in 2006, a group of stakeholders formed the Uterine Prolapse Alliance, which was very successful in advocating for more awareness to prolapse. And it actually ended up in the development of a national strategy. It leveraged lots of resources and increased awareness and demand for services. And this is a great example of something that could, in fact, what's come out of it actually recently is that there's a call for a reproductive morbidities unit within the Ministry of Health. So that would also be great progress if that can come about. And again, as I think Jillian mentioned earlier, the other opportunities for integration are that in theory, similar surgical skills are required for treatment. And this would represent, integration would represent an opportunity to increase national capacity for pelvic floor surgery, if only it was as simple as that. And I think Nepal shows that it's not quite as simple as that. And I think Laurie's going to speak to that also, since she's just arrived back from there. So the major challenges are the competition, potentially, between prolapse and fistula, and whether fistula, the hard-won gains of raising awareness and resources for fistula, would really suffer as a result of integrating services. Because prolapse is a condition that probably affects quite a lot more women than fistula. And it also, in terms of cost and care, requires a lot more resources. So if you were a government and you were looking at where you were going to spend your resources, you might decide to place them, to give them to the condition that seems to be more prevalent, rather than the one that, and perhaps simpler to fix, because as we've said, fistula surgery is not simple. It's quite often quite complex. So that would be a reason not to do it. Then generally as a generic challenge, that integrated services, even though I think everybody agrees that they're the way to go, both from a woman's perspective, they offer lots of advantages, but in fragile health systems, it's quite difficult to implement them, and it's been a major challenge to implement integration successfully so far. Then the third challenge, as I see it, is matching supply to increased demand. And again, I'd like to give another example from Nepal. Advocacy, the Uterine Prolapse Alliance, has been very successful, as I said, in increasing demand for services through advocacy. But the supply is not there, and it's overwhelmed the supply for human resources and just the infrastructure generally. So what Nepal has had to make some very difficult decisions about how to increase supply and coverage of services. And that's not just for prolapse surgery, it's also for emergency obstetric care, because what they have done to try and meet the demand is to contract the private sector. And that's been successful to some extent. It's definitely increased the supply, but there have been numerous quality of care challenges. And for example, with prolapse, the way that services are provided, they're almost exclusively provided by the private sector, and it has had some very bad consequences for quality of care, because there's been very little, unfortunately, very little accountability. And it means that actually national capacity is not being increased because these providers are not retained in any way. It's sort of, as I understand it, it's like a moving around like a circus of providers providing services in camp settings for prolapse. And I was told that actually some of the services will be set up for 48 hours to do their target number of surgeries that they've contracted with the ministry to do, and then they've moved off. So if women have post-operative complications, it's really difficult. And obviously it couldn't work for fistula. And then again, the human resource shortages, which is related to what I've just said. But as Jillian pointed out as well, fistula surgeons are in very short supply, and the technical skills that are required to do fistula surgery are probably quite considerably more of a higher grade than, say, for prolapse surgery. But I think Laurie will also speak to that. I just wanted to say one more thing about challenges in matching supply to demand, because we also have to take account of what other policies are being implemented to reduce maternal mortality and how those could impact on morbidity. And again, I'm going to talk about Nepal again, because Nepal has introduced free delivery services and an incentive for health facility birth. And that has had a knock-on effect on the ability to address reproductive morbidity, because there have been an increased number of health facility births, cesarean sections. So routine gynecological surgery gets pushed to the side. And indeed, it's actually not possible at the moment to meet the demand that has been generated by free delivery services. So yes, what we do know and what we don't know. Well, we are acutely aware that there are other morbidities that need to be addressed across what's sometimes called the incontinence spectrum, so that from fistula to chronic urinary tract infection, for example. But we also know that there's still an awful lot to do to eliminate fistula, and that's certainly the focus of our remit and our resources. Resources are limited, And as I've said earlier, it's a real battle to get resources and attention for morbidities, because rightly, the focus has been on reducing maternal mortality, and we could say in the long run that the things that will reduce maternal mortality will also reduce morbidities. But that doesn't address the problem of the great backlog and the fact that we don't know that we're reducing incidence of fistula or prolapse, really. So what we don't know, well, as Marge Kablinski has recently described, the information vacuum on the magnitude of the morbidities, the comparative evidence base we don't have. There's also a lot of confusion about terminology, I think, which makes interpreting the research quite difficult. Sustainability of existing fistula programs. Well, fistula surgery, fistula treatment is expensive. There's no getting away from that. So the reliance has been on external donors and will be for some time to come. I think I've covered the feasibility of integrating services in low resource settings. And I think the major difficulty and challenge, and what we don't know, is what would be the impact on the hard-won gains for fistula programming of integrating services were we able to do it. So my final slide, again from the street mural in Kathmandu. I love this picture, but this poor woman is obviously suffering from a very, very severe uterine prolapse. But it's, you know, where should we best invest our energies and resources? Should we look at trying to get better data? Should we just focus on eliminating fistula? And as we know, in rich nations, we don't see fistula anymore. So should we look at, there's obviously, it would be cheaper and perhaps easier to do integrated advocacy and prevention only. That's an obvious advantage. Or should we go the whole hog and try and do the whole thing? Just finally, I want to say on a personal note, and I know Jillian's already said it, I'm a midwife. I feel that we definitely still need to say that we need more midwives. And we're the specialists in childbirth, and we really are the health prevention professionals that are best placed to ensure the continuum care for women that will prevent childbirth injury. Thank you.
Thank you, Celia, and thank you for these last words about midwifery and midwives. This is clearly important. Now, thank you also for driving us in this new area that we are exploring all together to see how we can deal with more than fistula, with prolapse. You talk about Nepal, where the incidence is very important and it's well known, and we have here in this room friends working on this issue. Many countries in Africa particularly, we don't know, but we know because people are talking about that, but we don't know because we have no the data and no clear assessment of the situation has been made. So this is a new work, a new area of work that we are opening. And the challenge is to not lose focus. And when you talk about focus, Kate, I think it's very important. We cannot reduce effort to deal with fistula, but at the same time we need to try to respond to the big needs of different type of mobilities in the world. So thank you for bringing us here, and I'm sure that our next speaker and last speaker will also talk about that. Laurie Ramanzi is a pelvic reconstruction surgeon. She's based in New York. She is working. She is amazing because she's. We are lucky to have her. She missed the train, but in fact, she also tried to not miss the planes because she's coming. She was in Somalia. She was in Nepal recently. She's going at the end of the next week in Afghanistan, and she's doing a great work in training surgeons locally. And we have heard before that. The major issue of capacity building at national level was certainly a challenge for all of us. So Laurie is one of the rare surgeons that we have in the world, moving from place to place and working with the local surgeons. So she will talk to us about this work Laurie, you have the floor. Thank you very much for being here.
Thank you, everyone, for taking the time to come today. It's very special to see all of you here and so many women. I love it. Okay. Well, I feel a little bit like Usain Bolt anchoring the relay team here. I will not finish in 10 seconds, but you will see some mighty speed as I run through quite a number of slides. But what I'm doing is sharing with you a talk that I'll be taking to Japan in a couple of days. So please, I apologize. There will be a lot of data on here that is not specific to this audience, but I think if you can speed read, you'll find some of it interesting. Now, pelvic floor disorders, as listed here. Yeah, that's better. Okay, pelvic floor disorders includes things like obstetric fistula, pelvic organ prolapse, urinary and fecal incontinence, and basically anything between here and here that is not working right, that is benign. We're not talking about cancer here, all right? That is typically a pelvic floor disorder. Okay. And this is actually a picture on Mercy Ships, and what this picture is I recently had the opportunity to work there for a month with a local trainee, and they do a dress celebration when the women have had their fistula fixed. And so this is one of the fistula patients in her beautiful new dress, celebrating her, literally the rebirth of her life. All right. So why would we be debating or discussing or presenting the notion that we would maybe expand the very hard one and very necessary focus on an eradicable condition, which is obstetric fistula, to something a little bit broader that arguably is not eradicable? We have a history in Europe and America of obstetric fistula. It's a history. It's a remote history. In fact, the world's first fistula hospital was built in my hometown on what is now the site of the current Waldorf Astoria. And some of you, everybody here knows this, but the fistula hospital built by J. Marion Sims was the first in the world, and it was built in New York City in the mid-1800s, and by the early 1900s, it was rendered obsolete because we had anesthesia, so we could do cesareans, and obstetric interventions with forceps were saving women from deadly obstructed labor. And this tradition continues to this day, and you see it reflected in our, depending on the institution, almost up to 40% cesarean section rate. One of the number one indications for cesarean section in developed nations is what we call failure to progress.
That would be me.
Our obstructed labor has fancy terms like cephalopelvic disproportion or failure to progress. And in that instance, you're allowed to get stuck in labor for a few hours. All right, you get stuck. They figure out if Pitocin's going to help you or not, if they need to rotate the baby or give you some oxygen or whatever. If the baby looks okay, you get a little bit more time. But if you're really stuck and every non-surgical intervention has been entertained or employed and you're going nowhere, you've been stuck at 5 centimeters now for 6 hours, you get a cesarean section. And that reflects the simple fact that, bizarrely enough, in the human female, left au naturel, obstructed labor is ridiculously common. So if you want to eradicate fistula, you're going to have double-digit cesarean section rates. That's just how it goes. Anyway, so all this work has been done. Very needful, necessary work to rescue our sisters in developed nations who don't have the benefit of modern obstetrics, who were literally the last priority on everyone's healthcare list. And now with programs, international programs that focus on fistula, all these resources have been mobilized. And in essence, what happens is when you go to work in these centers to take care of these fistula patients, these women coming from these remote areas come often with a variety of conditions. Some of them are not fistula at all. And then you have to make a choice. Are you actually going to turn that woman away? It took her 5 days to get to you. Are you really going to turn her away just because she doesn't have a fistula, but she has a prolapse hanging out of her vagina? I know places where that has happened. So if we want to move beyond fistula with, of course, still it is the center of the universe of pelvic floor disorders in developing nations, we're talking about also taking care of women with pelvic organ prolapse, regular garden variety urinary incontinence and regular garden variety fecal incontinence, by which I mean urinary and fecal incontinence that is not coming through a fistulous defect. It's just you sneeze, you leak, you cough, you leak, you lift, you leak, or your sphincter is weak from multiple childbirths, and you just, if you're having a little bit of soft stool because of some virus that's passing through the community, you can't hold it, and you're out there and it's running down your leg. These women in developing nations, because of their second-class citizen status, when they develop pelvic organ prolapse, urinary incontinence, and fecal incontinence, their quality of life impact is at least in the same neighborhood, if not as severe as a woman with obstetric fistula. If your job is to lift and carry, to be the first one up in the morning and the last one to eat and go to bed at night, and you can't do your job, or you smell because while you're cooking, you're leaking, whether it's from a fistula or just because you have garden variety urinary incontinence, you can end up with quality of life impact that is in the same neighborhood, if not equivalent to that of a fistula patient, and we see this in the women who show up in the camps. I'll put forth the argument that including conditions of the pelvic floor beyond fistula is consistent with Millennium Development Goals 5 and 3. And in the interest of time, I won't delineate those. I'm assuming most people in this audience know what they are. You'll be seeing some abbreviations throughout this slide set. Pelvic floor disorders, genital fistula, urinary incontinence, fecal incontinence, and POP for pelvic organ prolapse. All right, so what we have here, when we think about attributable risk includes looking at women who are not exposed to the risk, women without vaginal delivery, as opposed to women who do have exposure to the risk factor, which is vaginal delivery. And if you want to look at obstetric fistula only, then these are all exposed women. If you want to look at pelvic floor disorders, you will get up into this area where you have unexposed women. You have women who've never been pregnant. There are women who've never been pregnant in my city right now who have severe pelvic organ prolapse, who have bad urinary incontinence, who for whatever reason also have fecal incontinence, and they need treatment. This also occurs in developing nations. So you don't even have to be pregnant to get these other pelvic floor disorders, whereas with fistula, by definition, you have to get pregnant and suffer through the horrors of an obstructed labor. And so what we're really looking at, if we want to think about this from an epidemiologic point of view, is getting into the neighborhood where you have no attribution to the risk factor. You're just going to take care of these women. Women with these other conditions share risk factors with women who have fistula. Now, the arguable risk factors are early marriage and young age at first delivery, and I'm just going to take a little commercial moment here to say that in every fistula series everywhere, and in the fistula camps where we work, yes, many women, young women, girls, having babies under the age of 15 suffer an obstetric fistula. It also happens to be their first pregnancy. The other up to 40% are women who've had many babies with no problem. But as a woman gets older, baby birth weights tend to be higher. The rates of gestational diabetes tend to be higher. This makes for big fat shoulders in the baby, especially if it's untreated, which for women living in remote areas eating rice all day, it is untreated, undiagnosed and untreated. Uteruses get tired. They just don't contract well after you've had 4 or 5 babies. In my training program, we call it multiparous is the word for many babies. You've had several babies. We called it the multip trap. A woman has had 3, 4, 5 babies, no problem. She's coming in with that 5th or 6th baby. You better watch her like a hawk because something's going to happen this time. You know, she looks like she's been there, done that, and you should just be able to come back when she says she feels like pushing. Trust me, you're going to come back, that cord's going to be prolapsed in the baby because things happen to women after they've had about 4 babies, and you really have to be careful. And we see this also in fistula camps. They have 4, 5, 6 babies in their remote village, no problem. With that 7th baby, they had an obstructed labor, the baby died, and they walk in with a fistula. And that's about 40%. So let's not assume that every woman with a fistula in a developing nation is some poor forced marriage 12-year-old girl. We also have up to 12,000 girls in the United States every year delivering babies under the age of 15. If you look at our health statistics from the CDC, about 12,000 a year. It's dropped down to 10,000 and change, so we're doing something right. But we've got, large numbers of girls, they don't get fistula because they either pop that baby out in the closet in the back bedroom, all right, because they don't even know they're pregnant. No, you know, the young ones, they get,
this is true. This is true.
they're dissociated. They go, and it comes out no problem. Or they're walking around, they don't know, do they have appendicitis? So somebody takes them to the hospital, at which point we figure out that they're pregnant, the family gets upset, but you know, if she goes into obstructed labor and fails to progress, she'll get what she needs to get to have the baby. And none of these 12,000 young girls in this country every year get a fistula. So really what fistula is about is lack of access to emergency obstetric care. That is the single unifying factor. We like to say that we don't want to see girls in forced marriages having babies at 13. Absolutely not. We don't want that. But please don't confuse cause and effect. Please don't do that, because you're doing disservice to 40% of women in developing nations who get fistulas at the age of 28, 32, after they've had 5 babies with no problem. Here are the universal risk factors. Getting older increases your risk for prolapse. The increased numbers of babies increases your risk for prolapse and obstetric injury, all obstetric injury, including fistula. Large birth weights and vaginal deliveries, especially prolonged vaginal deliveries, increase your risk factors for both. And then for prolapse, we've got repetitive strain injury, heavy lift and carry. It doesn't happen so much in developed nations, but it does in poor nations, especially in the western regions of Nepal, where prolapse is absurdly high incidence and prevalence. These women are going up and down very steep terrain all their lives from the time they can stand up and carry something, up and down every day, engaged in repetitive strain injury, including all throughout their pregnancy, immediately postpartum, and every moment in between until they pass from this earth. And medical conditions, connective tissue disorders, diabetes weakens connective tissue, chronic coughing and chronic constipation can also increase risk for other pelvic floor disorders. Now, I didn't really come up with this idea. I got this between a combination of seeing it walk into the fistula camps and reading Walker and Gunasekera's fantastic meta-analysis of pelvic floor disorders in low and middle income nations that are not fistula, where they found overall fecal incontinence rates in developing nations and middle income nations of about 7% with a wide range, urinary incontinence of about 30%, and pelvic organ prolapse at about 20%. This was including 9 studies from low-income countries and 21 studies from middle-income countries. And if we want to look, we'll start from back and go to front. For fecal incontinence, there's only 1 study from a developing nation. And trust me, if my colleagues in developing nations took the time and effort to do a study, it's because there's a real problem. I cannot tell you how difficult it is to gather meaningful, accurate data in many of these settings. So if they took the time, it's because there is a real and compelling problem. It's not an academic exercise for the umpteenth fellow to do on their 3 protected months of research time. That doesn't exist. So if they're reporting on it, it's because they want someone to hear them, that this is a problem. Fecal incontinence in developed nations, again, we have a lot of compelling evidence that will be interesting to compare as more data comes out of developing nations. But one interesting thing with fecal incontinence is it's usually about childbirth injury to the sphincter. Even if you don't tear it, every vaginal birth does a little bit of damage to the anal sphincter. And it may never, ever, ever be symptomatic. But if you look at the electromyographic studies and the sonographic studies, it's very clear that every baby that comes out of the vagina does a little something to the sphincter to make it a little bit lesser than what it was. Whether that will ever cause you a problem in your life, it may never come to fruition. But we see evidence of changes, let's call it that. And between 30 and 34 years after birth, that obstetric injury impact seems to fade. So when you get into women in their 70s and 80s, whether they've ever had a baby or not, the prevalence of fecal incontinence is fairly equivalent, which I find interesting. Urinary incontinence in developing nations, there are more reports on this because women are more willing to come forward with it than they are with fecal incontinence. And so we see incidences and prevalences that are all over the place. But this study in Ghana, they just looked at about 1,200 women walking into a regular gynecologic clinic for all indications, for all reasons. I have discharge, I can't get pregnant, my period lasts too long, what are these fibroids doing here? And they found that almost half of them had urinary incontinence. okay? And there are two types of incontinence. There's stress incontinence, which is in essence cough and leak, sneeze and leak, or what I like to call exert and squirt, all right? And then there's urge incontinence, where your bladder literally goes into what? Goes into avoiding reflex, and that's where we've seen those commercials, right? The cop in the middle of the street, and she's like, oh, gotta go. Because the bladder can go into avoiding reflex involuntarily, and it gives you a horrible feeling of urgency. And what we found in the States is women with urinary incontinence, it's about a third, a third, a third. A third have stress incontinence, 1/3 have urge incontinence, and the remaining third has a little bit of both. And so we see not exactly the same numbers, but again, these are small institutional-based studies as opposed to wide geographic area, full epidemiologic studies. But we do see distributions reflecting some mix of different incontinence symptoms, as we might expect. And again, if they reported on it, if they took the time to report on it, there is a problem there, and they want some response to that. And in Pakistan, we find also similar things. This one is the Ramanzi study, where they did a proper epidemiologic survey of women for gynecologic morbidities, and found that reproductive tract infections and menstrual disorders were in the 2 and 3 spots, with pelvic organ prolapse being number 1, with 41% of the respondents in that survey saying that pelvic organ prolapse was the thing that was ruining their life in Pakistan. And urinary incontinence in Western Europe and North America, I will not get into all of this data, but just notice nullipara is the word for never had a baby. So we see this. We see this also in Nepal. They have a big problem with nulliparous severe pelvic organ prolapse. Uterus falling out, never been married, never had a baby. It makes you fairly unmarriageable. And while this isn't about prolapse per se, this is about incontinence. You can see that we also see in wealthy nations, where women don't have nearly the strenuous life that they do in Nepal, stress incontinence, urge incontinence, and mixed incontinence occurring in the nulliparous population as well. It does happen. Pelvic organ prolapse, things falling out. It is in essence a hernia type condition. Think of it as a hernia happening in the center of the pelvis, coming out, expressing itself through the vagina. So in, what I was taught was that African women don't get prolapse. So this is just ridiculous. Of course they get prolapse. They can get prolapse. They get fistula, and they get prolapse. They get everything. So in the Gambia and in Ghana and in Nigeria, all along the western coast of Africa, you see this data coming out that they have a big problem with pelvic organ prolapse, a big problem, 46% in one survey in the Gambia. And the Gambia is a tiny place. It's a former British colony. As developing nations go, it's doing pretty well, and this one study had almost half the women with significant pelvic organ prolapse to various degrees. And this severe at 1.2% is consistent with the data that we have in developed nations, where severe prolapse runs about 3 to 4% of women with prolapse. Now, severe is about the anatomic description. It doesn't necessarily correlate to how the woman perceives it, how much it may or may not be bothering her, and whether she wants something done about it. You often find a good portion of the women with mechanically moderate prolapse with major symptoms wanting something done about it. Not all, but most. And most women with mild prolapse don't even know they have an issue, just for perspective for the audience that's not medical. Okay, and in Asia, we're seeing more and more data coming out here. Pakistan, in one large series of some 1,000-something women, 20% had pelvic organ prolapse. In Nepal, there are various reports, but I think probably the most accurate one is a UNFPA 2006 report that looked at reproductive morbidities and went to 2 areas in Nepal and surveyed 2,000 and change women and pulled in a subset for exam. And what they found on examination was that about 10% of these women had significant pelvic organ prolapse. And only 3 had fistula. So it was a very different rate. But again, it was only 2 regions. And what I just saw when I was there is they have a big problem also with obstetric fistula. They really do. And I got to do a fistula prolapse case, which is one of my arguments for not only do you get women with prolapse coming into these camps, and they've traveled from far and they don't have any money and their lives are being ruined, But in places like Nepal, you can get patients with fistula and severe prolapse. So if you don't have that skill set, if you're not walking in with that dual skill set, if they're not working in a center where people can do all those things, what are you going to do? Close the hole and send her home with her severe prolapse? When you can do both at once? So we did both at once. Everyone was very happy. Patient was thrilled. It just highlights the fact that these things belong together. In Europe and North America, we have what are called urogynecology centers, where all these things, we don't see a lot of fistula, but we do see some. You can also get fistula after hysterectomy. You can get fistula as a result of radiation therapy. You can get fistula as a result of, people who travel, who go somewhere and get bizarre infections. There are certain very aggressive infections that can cause fistula as well. Anybody have or know anyone with Crohn's disease? Okay, so Crohn's is an inflammatory condition, and lots of people with Crohn's are constantly creating fistulas between their rectum and the outside world, including the men. But for women, it often fistulizes right into the vagina. And so we have reasons to be fixing fistula even in wealthy nations. And in the 2006 survey, we saw both fistula and prolapse, and mostly restricted. The severe prolapses and nulliparous prolapses mostly in the western region. I'm sorry for the graphics. You guys are not clinical. Sorry about that. I didn't know. But this is Democratic Republic of Congo. You can't get much more sub-Saharan Africa than the biggest sub-Saharan country. It's right in the center of everything. And I've been there many, many times to fix fistula. And what I realized was that, in the other room, they were doing a lot of prolapse, and I stuck my head in and watched what they were doing, and I said, can I come back and we just do the prolapse patients next time? Let's just do the prolapse patients. Let's not forget the but have your fistula camp, because they're excellent fistula surgeons there. I just go there to pick up the rate at which the cases are done. I said, but I think I can add a little value if we do this. And so what happened was, this young woman, she's 25, she had her first baby at 16. She's already had 4. She doesn't practice birth control. After the 4th, her uterus fell out. Her husband, illiterate, everybody's illiterate, and she lives far. He took this as a sign of infidelity, as if this woman has had 5 spare moments in which to be unfaithful. But he took this as a sign of infidelity, and her family and his family sided with him. For 2 years, she had not seen any of her 4 children and had not been allowed to go near the village because she was an evil adulteress, according to this prolapse. This is her cervix. Under this portion of skin here, if I were to cut into it, we go right into the bladder. And back here, this bulge back here is her rectum. And in between the rectum and the bladder, right around in here would be then her uterus. Now, prolapse doesn't get much worse than this. But what's impressive is that in the United States, we typically don't see this degree of prolapse until you have prolapse in your 70s or 80s. But in developing nations, you'll see this degree of prolapse in very young women. You'll see this degree of prolapse in a nulliparous woman in Nepal. How is she going to get married looking like that? It's not going to happen. If she can't get married, she has no life. She has no value. She has no worth. She's not having her period. She has no value. She has no worth. So what we did with this woman had been to 2 fistula camps at this hospital before and had been turned away because you don't have the right condition. It's the same position on the table. It's the same headlight. It's the same retractors. It's even the same dissection. There are 2 parts to the dissection and then the suturing. All right, so it's the same dissection techniques, different suturing. It's the same. So we fixed her. I never saw, the fistula patients are always very grateful, but the fistula patients also are like reborn because they face down death with their obstructed labor. And so they are very, very grateful. This woman couldn't stop crying. This woman was so grateful. I'd never seen a patient so grateful. She took pictures. She wouldn't let go of my hand. And I'll tell you, my colleagues, because I taught them how to resuspend this uterus and not sacrifice, because that's the other thing. When you get a young woman with bad prolapse in a developing nation, and you take out her uterus, and everybody knows your business. So they know that you're not a woman anymore because you're not having your period. If you're not having your period, you can't make babies. If you can't make babies, you're still going to end up divorced, even if everything is inside your vagina, where it belongs. So to teach them a uterine resuspension technique was incredibly valuable, not only to this individual patient, but every young patient coming back to that center. And I'll tell you what, the 6 times I went there before the 7th time, I never got an email from any of my colleagues thanking me profusely for showing up. After this time, when we did a bunch of these type of cases, I still, to this day, and I haven't been there since 2008, get emails about having taught them this uterine resuspension technique and helped them with upgrading their general, because it's not just about lifting the uterus, there are other things you have to do as well. Upgrading their techniques a little bit, making it simple for them, teaching them how to test the bladder with simple, low-cost things that they were already using. To this day, just the other day, I got in, oh, so glad, thank you again for teaching us your technique from below, and when are you coming back? Anyway, pelvic organ prolapse will survive fistula. Fistula is eradicable. Other pelvic floor disorders are not. They persist even when women get the vote, even when women get educated and own businesses, even when they don't have to do this. This is women of southern Italy, carry wardrobes, here's the children, carry heavy things up and down hills and make babies at the same time. Even when all of those conditions are gone, we still have pelvic organ prolapse. And so that's not, I think when it comes to fistula programs, there is a silver lining in all of that in terms of self-sustainability, because in these areas, you will have educated, wealthy women who have severe pelvic organ prolapse. And if they don't have to fly to Europe to get their care because the local surgeon knows what to do, you then create the potential for that doctor to have income. If you train them only to be a fistula surgeon, they are forever dependent, practically, on third-party funders, international funders, because the fistula patients, by definition, will not come with any kind of personal resources to pay for services. And everywhere, services cost money. So if you can have that wealthy woman who would have flown to Paris for her surgery, who now can go to the capital in Niamey, in Niger, and get her prolapse surgery from the doctor who can do the equivalent techniques to what would have been done in Paris, and the next time she goes to Paris, she can spend that money on shoes, that's good. You can develop self-sustaining centers that way, potentially, or at least partially self-sustaining. And there are centers that are already doing that without any help from any third-party funder. It's very obvious if you're working in the places. The pathophysiology of pelvic organ prolapse is really fascinating. Yes, having babies is definitely a risk factor. Being overweight is a risk factor, chronic cough, but we're also finding all sorts of things that are in essence genetic. I won't bore you with the details, but this entire slide is all about the genetics, differences in body composition, differences in the way enzymes works between women with prolapse and women without prolapse. Triaging, when we look for fistula, we often fill the bladder with blue fluid and look for where the hole is. And we can use the same techniques that slide seems to be missing, to fill the bladder and check for urinary incontinence. And to finish up, this is my trainee on Mercy ships in Togo. We spent a month doing nothing but fistula. Nothing but fistula. And toward the end of that month, he's an excellent surgeon, fantastic. We took the 10-hour drive up to his regional center in Dapang, which is a catchment regional hospital for 600,000 people. We had a nice conversation about doing fistula work in Dapang, which was not active at the time, and he said that would be wonderful because we know we have fistula patients here. We don't even know how many because they're so poor and they live so far, and they know we don't do it. But I know that if you give him the instruments he needs and he can start doing them, they will come. I said, okay, great. Well, what is your number one? So if you're not sure about phys, what is your number one problem that you know about for women's health care? And he said, oh, we have a much bigger problem with prolapse. Can you help us with that? So that's my argument.
Thanks. Fantastic. Fantastic. I said she was amazing, and I think it's a confirmation. I have not personally heard this presentation before, so it's really great. But I would like to note also that, and you have noted, I'm sure also that the patient of all the people working on this area of fistula and women maternal mortality, women morbidity is fantastic. So thank you very much for all the panelists. Not spending more time, now the flow is to you. I don't know, under your controls on how much time we have. I know that we have a reception after that, we can have a drink, so we can continue discussion between each of us, but how much time we have for the... 20 minutes. 20 minutes, great. I think it's very good. Okay, Please. Sarah? Yes, we have a mic circulating. Thank you.
I'm taking the privilege of being the third UNFPA person here. I thought that was fantastic. So I'm very happy to hear these tragic stories and also hope. But I guess what each of you were saying was about the lack of fistula surgeons. And there have been some policy proposals here in Washington about getting more lorries into the field, the idea of bringing more American doctors in. Can you all talk about the fistula surgeon population? When you say there are few, where do they come from? Where should they be coming from? How should we be getting this training going?
I'll jump in with not necessarily the only point of view worth listening to, most certainly. One of the things that our foundation encourages is, where possible, we invest funds in surgeons that actually live and will continue to live in the countries where fistula is prevalent. Lori is, and she knows this, she's one of my heroes, and she's also fun to go to dinner with, but she's, she's incredible that she's decided to leave a Manhattan practice, and mid-career divert her energies to, we just spent week together with the nice boy with the Kalashnikov in Somaliland. So she, in some places that most, mid-career surgeons wouldn't choose to go. And that's wonderful, and our foundation has funded her and will continue to fund her on specific projects. UNFPA does as well. And, it's great because she's helping, well, the example she gave in Congo about prolapse, but she's also helping fistula techniques. Surgeons go up learning curves, and it's fabulous. But that's not the way forward, because there are not enough lorries in the world. And the other thing about fistula surgery, while certainly there are fistulas that occur every year in this country because of basically errors, radiation accidents, tragic, vacation, I don't know, what did you say it was, like viruses or something that creates holes. The reality is you just aren't going to see, because of the eradication, by and large, of obstetric fistula. Surgeons in this country are not going to have the same range of experience, generally, as surgeons that are working full-time in those countries. Now, another guy that we fund, who anybody that's a regular reader of Nick Kristof would have seen a wonderful Mother's Day piece that made him the hero. At some point, maybe we'll get Nick to write one about Lori the hero. But a guy named Steve Arrowsmith. My first meeting with him, back to my first Mario Fistula Hospital experience, he was actually there in 1994. And we've also funded him to go places, Angola, Bangladesh, where he's willing to go in and basically do the more complicated cases that have been saved up for him, take existing surgeons up a learning curve. But some of the proposals that sort of look at the U.S. as a center of excellence on medical surgical treatment generally and say, oh, we're going to create a center of excellence here and sort of transport that, that's not an approach that we think makes a lot of sense because of where this happens, because, and other panelists have talked about this, but I think it's important, and Lori could write a book on it, because fistula is a trauma injury. It's and Jillian mentioned it. It's necrotic tissue. This is holes that happen in places. And again, Lori could write a book on it. I've sat in ORs and mostly just observed, and oh wow. But degrees of scar tissue, size of holes, location. Is it close to the vaginal opening? Is it up near the cervix? How much collateral damage is done to urethras? These are injuries that just your average surgeon is not seeing, thank God, in this country. So the notion of sort of investing in people that will kind of be medical tourists, not so much. I don't see that as the way forward. We've invested, and we're not alone, and I mentioned it because UNFPA and USA deserve credit for being kind of the initial sort of angel funders in a FIGO program, which is, again, the International Federation of Gynecologists and Obstetrics. They've got a very seriously competency-based program to take surgeons up multi-year training efforts where you have south-to-south collaboration. We have a grantee in Bangladesh who trained in northern Ethiopia with the former medical director of the Addis Ababa Fistula Hospital. And that's our theory for, we buy into that other approach that, has been created with help from UNFPA and USAID. That's what we think. It's a lot of words, but that's
Celia, very briefly on the same
Very briefly.
question.
I just wanted to say that obviously one of the most important things to most health professionals is continuing medical education. They want to improve their skills, and And that's something that's sometimes ignored, that we might train a fistula surgeon. And as Laurie said, obviously, if you expand your remit, that gives you more career options. And obviously, women with fistula tend to be often very poor, so there's not the ability to do surgery on wealthy women, or just to have a larger area of clinical practice. But it's so important to be able to continue to improve your skills and your knowledge, and I think perhaps that's an area we need to invest more in.
Just to add one point about that, I think your point is very valid, because we know that there is a trend to think that we will be able to solve the problem in the developing world just to add some technicians sometime, and then the problem will be solved. This is again and opposed to all lessons that we are getting from the field. We know that the only one way to solve the problem in a sustainable way is to train people to deal with their issues in the countries. So I think there is an international consensus on that. No one will pretend that we can do differently. We all know this Mao Zedong old proverb saying that if you want to deal with hungry, you have to train people to fish and not providing them food from outside, etc. So the capacity building, we said that already, the capacity building, there is no reason why a surgeon in the South or in the developing world cannot learn and become a perfect, excellent surgeon for fistula or prolapse. There is no any reason. And Laurie has excellent examples of colleagues. We become excellent surgeons. So the way is to train, and we cannot go faster than the amount of funds that we have will allow us to do that. But we have to do this way, and I think it's the only one point that we can say this. Thank you for this question, Madam.
Training. I'm just wondering how much is being invested in pre-service training, and especially in these countries where there's such a high prevalence, because I think it needs to start at that level, pre-service training. Oh, so my name is Rosa Molo and I work for SEDPA.
Thank you for this question. Excellent point. Who wants to answer? I have some ideas on that. I don't know if you want to reply. Pre-service.
I'm not sure what pre-service training, I'm sorry, I'm not familiar with that terms. Can you just
No, pre-service is education.
Schools, in the schools of medicine or schools of nursing, and before the doctors graduate.
We have an excellent example, if I may jump on this. In Ethiopia, each medical student is going through, for some weeks, the fistula hospital in Addis Ababa. So each medical doctor, surgeon or not, is going through this issue. Luc not practice very much, because in few weeks you cannot become a real surgeon for that. But at least the awareness of all medical doctors is increased. But training of many or all doctors during the in-service training would be absolutely impossible. But the point I'm trying to make is also that a proportion which is absolutely very, very small, all these doctors in Ethiopia are then interested and working on the obstetric fistula issue. So we know that this is not the way. We are talking here about fistula surgery, which is a specialization. It's a difficult surgery. And this is coming when you have already acquired a lot of skills in surgery, and then you can move to this type of surgery. I talk under your control.
Under my control? That means I have control of you? Really? All right. So speaking to that, there's an exciting development happening at the Korlebu Hospital in Accra, Ghana, that I believe is the future for fistula training and pelvic floor disorders throughout all developing and middle-income nations. Without asking for any help or getting any funders, they have launched in this past 12 months a proper post-residency level training urogynecology program based on a combination of the American Urogynecologic Society's fellowship paradigm and the Royal College of Obstetrics and Gynecology Urogynecology Fellowship paradigm in Britain. They have, in certain regions of Ghana, a high prevalence of fistula, but if you get around Accra, which is like New York City, there's hardly any fistula because women have access to care. And so they will be addressing everything. They will be doing the prolapse and the incontinence and the fistula where they occur. This will be a proper 3-year training program. This is what is needed everywhere in the world, not just in developed nations. And wherever these sorts of training programs occur, they can address the needs therein. We have very few obstetric fistula here in the United States, and so you're hard pressed to find someone who can handle it, but there are ways to find it. And in places where obstetric fistula still has either regional or nationwide high prevalence, that's the way to do it. That way they learn the full range of skills, right? The full range of skills. And they've reached out to international organizations, but only after they started, to see if we'd like to participate. So the International Urogynecology Association said yes, and we'll be participating with their training program. That's what I would like to see more of.
Celia, please.
In terms of prevention and pre-service training, I'd say UNFPA, why am I speaking for UNFPA? But in the Strengthening Midwifery program has really tried to tie together fistula prevention and midwifery training. And I know in Nepal, where they're just about to start training their first midwives, they have specifically created modules on fistula and prolapse prevention. So that's an important development. We've also, Engender Health has collaborated with the East Central and South African Nursing Council to produce a nursing curriculum which deals with prevention and treatment and care for nurses, which is just about to be rolled out. So those things are very important, and I think that's I'm glad you raised that point, because
Please, Jillian.
Thank you. Yeah, I think a lot of progress has been made with pre-service training, but when we do missions into the field where, for example, obstetric fistula is a real problem, there are still a lot of gaps in the national curriculum of doctors within countries and midwives and nurses as well. They're very good on the prevention of morbidities, the prevention of fistula. That's all about their work, the role of the midwife. But there still needs to be a big push on kind of early management of morbidities, of fresh, for example, vesico-vaginal fistula, a certain type of fistula as well. So there's still more work to do on that. And thank you to Celia for mentioning UNFPA and partners, notably the ICM, their global midwifery program, health system strengthening, really expanding and staffing up, skilling up midwives across the world. And all of that will be incorporated much more into curriculums in the future. I just wanted to just make a comment about that often we have, the Campaign to End Fistula has a website, it's endfistula.org, and we have a kind of forum where people from the public, anybody can send in questions or comments. And we very often get questions, for example, from American or Canadian doctors, professor in obstetrics, saying, I would like to give some time to the developing world. I have been a professor in obstetrics for 20 years. Where can I go to provide fistula repair? But the problem is, like Laurie, like many people have mentioned, they have never come across it in their own work, in their own environment. And so our systematic reply to them is, do not touch any obstetric fistula in the developing world unless you, like your brothers in the developing world, have had specialized training and that you are classed as an expert, because only then should you touch these cases. Because the first time that we attempt to do the fistula repair, that is the best chance that that woman or girl will have a successful repair, because each subsequent attempt just creates more scar tissue.
Thank you. Yeah, very good point. Madam, please. The mic is coming. Voilà.
Hi, I'm Nancy Coviello. I'm here with a Voice of America new initiative called the Africa Health Network, which has just been launched in 2012, actually in June. And I have a couple practical questions. Where is the fistula map available that you mentioned? And the name of the hospital in Ghana? And then, like this year, we broadcast in 13 languages, health news and information across sub-Saharan Africa. And I know mostly in English and a little bit French, but we did 2 video profiles focused on fistula. One, a wonderful surgeon in the Ivory Coast. His name, I believe, is Kwame Bile. And he has an amazing program. So we profiled him, and then we profiled a patient going for her surgery in Nigeria. So sort of my broader question is, especially for the media and for a special project like this one, how can we positively contribute to the work that you're all doing?
Jillian, it's for you, I think.
I would say jump in on the fistula map since we were the primary sponsor of that one. Just global fistula map, and it's not it's static right now, but there's a new questionnaire that we're going to be submitting to the field. Obviously, the data that's on there is already old because it tracks cases from a year and a half, 2 years and a half ago. I appreciate the work that VOA is doing. I had actually done a television interview because it was broadcast overseas. Our communication person's right behind you, and I want to do an introduction afterwards because she's a dynamo and she's new to us. But we have partners in 19 countries, and we'd love to connect you with some of those. I know Jillian does as well. We have pretty intimate relationships with some of them, and we do send them money, so they tend to reply really quickly. So if we can be helpful with either patient stories and we keep patient stories, we actually ask for that with all of our grantees, real patient stories that we can use to basically convey the nature of their work in the field. So we'd love to be helpful. Do you guys?
The hospital in Ghana is Korlebu, KORLE-BU. Korlebu.
Jillian, you want to add something?
Yeah, just quickly. So I think I put the website for the Global Fistula Map, but there's an even easier way if you didn't manage to note it down. If you just do a Google search, Global Fistula Map, it comes up, many hits for it. And just open the initial page, and there are many, many layers of the map. It's really, really fascinating. It reflects 2010, and we are working hard in partnership to put 2011 on the map. But take a look. It really is fascinating. And please send in your ideas through the website as well. If you see that anything could be improved, we really welcome feedback to make kind of the data more valid and more useful. I'm not a media or communication specialist, but I work with a great team with the partners, but also within UNFPA of media and communication branch who work specifically looking at how best to get messages across, health messages. And it's a key part of our work, or the advocacy work of the campaign to end fistula. And like I mentioned, I think a lot has been achieved, and yet I am convinced that the real role of advocacy, it's still there. It's at the end of our fingertips to seize it and really raise awareness much more about this, to have a greater impact. And I would be very happy to put you in touch with some of our team in UNFPA or some of the partners who are working on communication issues to really spread the word further.
Good, thank you. I think, yes, please, madam.
My name is Risa Kayuzia, and I'm the Executive Director for Action for Reproductive Health. I'm also the principal founder of the organization, and we are doing male involvement, but our focus mainly is on maternal health specifically. And I just wanted to share that some of the experiences that we are getting in our communities is some of the VVFs that we have seen in the community are actually with the mothers that are on the second pregnancy or third pregnancy, is still early, but because of delayed in the community, being delayed in the community to be taken to the facilities, they have ended up with a full bladder causing the VVF. The problem is some of the facilities that we do have manpower, but these people don't take the community members don't take their relatives to the hospitals. They keep them in there. So my worry is that while we teach doctors, while we teach midwives, while we have manpower out there, we have got communities that are not going to cooperate to bring the patients into the facilities. So if it was possible, we would also put more effort in community education, trying to reach the communities themselves, to teach them to take responsibilities, to take their patients, to take their relatives into these facilities. The other question I had was for Dr. Laura. You are doing urology. We are doing male involvement. But our male involvement, we don't want to put them off. We want also them to share on what these women are receiving. Like if we are asking them to come and help the mothers, they should also have some part. They should also have some help. Is there a possibility also that in your area there could be something that could help these men, like with their few problems that they have, urological problems that they do have?
Right. Wherever I've worked, the male urologic problems are almost always addressed if they come forward, as you say. So I've never been, and I've had the good fortune to work in many, many, many different centers. In the centers where general medical care is provided, they know that I'm there. There has never been, it's never been evident to me that the men are not getting care in a timely fashion. So am I understanding your question properly? Male involvement, you're talking about male urologic problems?
Yes.
Yeah, she is.
Yeah, that's it. The problem that I'm talking about is that I do come from Uganda,
Mm-hmm.
and men never go for any kind of
that's international
assistance at all.
The women have to drag them.
Yeah. And it's a sad story, because at the end of the day, men end up with a cancer, like prostate cancer in third stage, last stages.
Yeah.
They don't know that part of what women go through may be contributed by them, like things like STIs and all that kind of stuff. So the reason I was asking is that while I'm doing male involvement, I want them also to have the help so that they can be motivated to help the women at the same time.
Right. Yeah. Well, I think whenever a community has gotten to the point where they're ready to embrace preventive health care, then selling that to the community can be a real struggle, because they don't know. But in communities where I've seen, for instance, prostate health being sold successfully to men, is just let them know, if you don't do this, you could be impotent. They'll come in.
Yeah.
That's good.
Kate?
I asked for just a little floor time to plug something that's happening next week, which many of you may know about already. On public television on Monday and Tuesday, the 1st and 2nd of next week, the documentary Half the Sky, that is Nick Kristof and Cheryl Dunn's book turned into a 4-hour documentary, is going to air. Since really fistula, we've all talked about, and everyone here has hit on it, is really the result of a system failure. And why does that system fail, and who does it fail? It fails women, particularly poor women. The whole idea of the book and the series is to create a movement so that we can help address a variety of bad symptoms that tend to happen more often to women, and particularly poor women. And so certainly tell your friends about it. It's going to be available on DVD afterwards. There's a wonderful website, Half the Sky Movement, which gets at not just maternal mortality, but sexual trafficking, forced prostitution, economic empowerment, education, a variety of sort of basket of issues that affect women. And I think, but then obviously the world, since we're half the world. The other thing I wanted just to mention that's quite exciting, and this is Nick Kristof's vision, is to really take the film and turn it again into a movement. There's a concert in Central Park on Saturday featuring not just Half the Sky, but some other sort of poverty alleviation organizations. But he's also put together a really exciting game on Facebook. And I'm so not even a Facebook user, true confession. Jessica's helping me. I'm really kind of disabled that way. But there are literally tens of millions of women actually in this country that play games on Facebook. And next, this fall, and actually November 13th, there's going to be a Facebook game. And there's about $600,000 that's gone into developing it with UN Foundation money, Ford Foundation money, Intel, et cetera. And I'm really excited this week because Johnson & Johnson, which is really the biggest private funder of fistula surgery and has helped us enormously over the last decade and done that in a kind of quiet, just doing it because it's the right thing to do kind of way, has stepped forward to support the game with $250,000. So the money's actually coming from a cause marketing budget, so it actually will be triggered and flow to us as people play this game. And the game is designed to create basically positive pathways for young women in developing countries, particularly India and Kenya, the way it's designed. It's still in development, but the ways education, nutrition, basically staying away from, sex trafficking if you can avoid it, or having people in your life to help you avoid it. The game is going to be structured to provide basically benefits and education along the way, but the literal benefit to us, the Fistula Foundation, and then to the institutions we fund will be surgeries being funded. Room to Read, which is another one of the main NGO partners, obviously working on literacy, has lined up $250,000 from Pearson. So it's us and Room to Read right now with real tangible stuff that's going to flow in the form of books and surgery with the playing of this game. So look for more about that. And again, it doesn't fit every demographic. I'm going to learn how to play games, but there's a whole world of people. There's like 100 million people on Farmville. There's people that build like those virtual farms. I mean, anyway, so there's my plug. But next Monday, Tuesday, watch it. Tell your friends to watch it. Tape it.
Thank you for reminding us. The world is crazy. We have not responded to the first part of the question. So just before closing, and we will close in 2 minutes, I wonder if Jillian wants to respond about the community mobilization, community awareness, because I think this is a very important point.
Yeah, and thank you so much about the comments about Uganda. I would like to just say one of the key things that we've seen that really, really works to mobilize communities and to raise awareness about safe birth practices that every woman should deliver in a recognized health center with a skilled birth attendant and be referred should a complication arise. But one of the key strategies that we've worked is working with grassroots community networks. And you have some amazing groups in Uganda. In fact, they're almost role models and you're to be congratulated. One of them is a group called Terawoda. Another one is the Ugandan Village Project, doing amazing work, sensitizing communities. But also what really, really works is, remember I talked about the fistula advocates, the women and girls who've suffered from fistula, who then receive some basic training and communication building skills to then go back to sensitize their own communities and populations about, look what happened to me, this is what I suffered, this can be prevented, and to prevent their sisters from ever having to suffer what they suffered. And believe me, there is no more powerful vehicle for delivering a message about prevention of morbidities, prevention of obstetric fistula, and improvement of maternal and newborn health than a woman or girl who can go back to her community and deliver that important message. So the other great practice in Uganda, and I just want to flag it up, is Uganda is also really the role model in the world for this Minister of Health National Task Force for Fistula. They are really doing amazing, innovative work, reuniting the partners around the table to look at the whole national kind of picture of what's happening for fistula, bringing all the partners together like we do at global level. Very important to do that within each national context where fistula is a problem as well. So well done, Uganda, and thanks again for your question.
Yeah, thank you, Jillian. And beyond Uganda, we have in the campaign to end fistula a number of small or big NGOs working in many countries precisely on this issue of mobilizing the community to ensure that the rights for treatment will be fulfilled. So I have nothing to add. We have a glass now all together. I think it was extremely interesting to hear these panelists that I would like you to really applaud, because they are passionate and knowing the field and the issue so well that I think we learned a lot today. So thanks to 4 of you, my dears. And thank you again for the Woodrow Wilson Center to welcome this event. We are very grateful to you. Thank you.
Thank you, and please stay for the reception. You'll find some snacks.
That word, I'm gonna call you passionated.
You go downstairs. We have some pills that we're
Okay.
giving
You have said that you wanted to say. Yeah. Good.
I think we should have said, though, Luke, we should have introduced you as we said.
Yeah, but it's not my job to introduce myself.
I got to go back to that you were actually
I need to go back to the
original clinical guidelines.
Hi.
Hi, I'm a fourth-year OBGYN resident.
Oh, okay.
I'm representing ACOG here today.
Oh, fantastic.
I'm actually for MFM, but I'm
Okay. Well, then,
gynecology.
maybe you should. Well, with MFM, you can work on prevention.
Great, that's great.
Yeah, because, you know, timely, when to do a cesarean, how to, there's a whole, okay, for your MFM fellowship, all right? They're
Crazy world on this.
But I want to do what we do now. They are so confused by the graph that they miss the concept of falling off the curve. They're like, the graph, they get hung up. They've never seen the graph in their life. Okay? And so, anything that develops that would push that, I find when the photographs is part of the
Report, I said, you know, this is our true north, all these patients. And so we don't get any government money, we're not going to go after any government money, we don't want to be that, we're this. And, you know, I'd worked on this for, she was younger, so I could talk to her a little bit like I did in here about how I, entered the fistula field and spent 7 years now working on nothing but it. And here's what I've learned. And it really went, I thought pretty well. I really said I'm a resource, and let me connect you to other resources. It's not just me. Let me connect you to Lord Patel, because I thought you could talk. Lord Patel is in like House of Lords. He's an MD, born in Tanzania, but not knighted. He's given us Order of the Thistle by Queen. But he's an MD. He's a cancer researcher, and he chairs the Vigo Fistula Committee. So it's like, I think that trumps Lewis Wall. I mentioned Lewis Wall by name, and I said he wrote, one of the best sort of meta-analysis of the field. It was written maybe, 8 years ago, whenever it was. And I said, that had value. One of the field has moved
what happens is, so OBGYNs very often end up being emergency triage docs because women kind of prenatal care, and the family only brings them in after they were done everything. Sometimes they just need prayers. They try, we'll put her on Constance. Okay, well, bring in the cutter. When they go in with the something sharp, they just start slicing up
In 5 days? I can't believe you've been there and back.
How did you get on with Dr. Bukhari? Because
that's exactly, and I would say where it left, and I haven't talked to Sarah because I just met with her and we took lunch and came here. But I would say that the opportunity is, you think about being the staff person, your boss is really busy, she's got a lot of things she wants to quote, do something. And so, because the end of it was, I think she still wants to do something. I feel like the conversation started with you guys at a letter, and then it opened up some room to.
Right.
Okay. And you've got different suction and the anesthesiologist is and there's no So, if the woman survives that, she often does
It went well. Yeah, maybe, but there's issues. What I would do, again, if it were just me,
So the OBGYN.
you want to work on fistula. Oh, the other thing I told her, by the way, it was what I mentioned up here, which is the London School of Tropical Hygiene is coming out with study. I mean, our board member is the deputy maternal health officer at Gates and ran UNFPA Pakistan before, UNFPA's chief policy officer, Grant Stoney. Saw the research back in February, January. So, I mean, it's real and it's going to show.
I will get thanks for that insight.
Yeah. No, it's not that they're not doing anything.
Yeah.
I even know an OBGYN who runs a fistula center and does OB-GYN.
Somebody's best guess based on Nigeria and someone else
It's got a fistula. So get these women in here in labor before they have a problem. And here's what he gave them like a short list. He brought them to the hospital.
He's kind of the supervisor.
It's a problem I get up and think about every day, and I put my life against it every day. But it's not the problem in terms of the dimension of it. That
I'm in touch with all the people on the ground. I won't tell you how many hours I'm on my computer emailing per day, but it's almost round the clock.
When you wrote it back, immediately he responded.
Yeah, my computer's on the whole time. If I'm cooking at home, I'm responding to emails as they come in 24 hours a day. Some people would say it's probably not good.
OBGYN resident.
Yeah, I know.
And we already did like, okay, we did that. Untrained birth attendant.
She's a. That's what she said.
She already knows what I'm talking about.
You wrote the communication and fistula thesis. I had a look through it. I didn't read it all, but very, very interesting. About, what do we call it? There's no correct term. It's such a You could have answered some of the communication.
Local woman, just hanging out. And it's not easy. I mean, you would think that if you introduce some common sense and talk about the advantages, that they would just
how do we get out?
Then there's the whole thing with it, not in every community, but in certain communities, if you end up going to the hospital to deliver, that means that there's something wrong with you as a woman, and there's probably something wrong with your sisters too. And if your sisters are unmarried, one of the influences can be that you can't go to the hospital if you're having a problem. Your sisters are not married yet. You can't do that to our reputation.
I think it ended in a good place in the middle ground.
Do you understand? So there are barriers to care that are deeply entrenched and cultural, and it's not for some outsider to fix that. That's all about education. It's all about education. People get educated. We have that problem here. People wouldn't go to the hospital for anything because when you go to the hospital, you die. I mean, for everything. I grew up with people in Tennessee who.
I'm in Mississippi, so.
Okay, you know what I'm talking about. That you have to drag them to the hospital, and they should have gone 3 days ago. Because if you go to the hospital, that's where you go to die. You go in there, they're gonna kill you. I mean, it's like that happens everywhere.
I tried to get Louis Wall to talk to me.
That's true. That's true. Are you taking the 7 o'clock train?
I am. Yeah, I am.
You look like you're leaving the building.
No, I'm
Elvis has left the building.
I'm just hugging.
Good meeting you too. Have fun at ACOG. I won't be there.
Yeah, I've been doing political advocacy work with him, basically for the Monday with Yale House Fellowship, which is like similar to the Pain Fellowship.
Okay.
For attending, so.
Excellent. That's
going
exciting.
back tomorrow to be on call on Saturday.
All right. Have fun.
Back to thinking about
Is May just still vertical?
Yeah, I'm so tired, I don't even have jet lag.
That's great. Half the sky movement with all these
I don't want
facets
to
of-
stop you from getting food or anything like that.
No,
But I just wanted to introduce myself. I'm Ariel. The presentation was awesome. Really, really interesting. I'm here. I'm an intern with Anywhere, which is
basically just said,
that's
so
working
what
on
his reaction
developing
impression
a
was.
medical
His name wasn't mentioned in
tool
the email or in his reply. All he said was, that's interesting. I remember being in Mali. It's a very well-meaning
So I was just
American
curious
surgeons
about
basically shredded a woman's vagina. I mean, I can't remember exactly the words he used, but that's the mental picture. In other words, he really got the notion of well-meaning people doing
There's a
harm.
lot of places the electricity goes out regularly. And the sterilizer's running, and if it's in the middle of a cycle, they have to wait for the power to come up and run it all over again.
Right. Yeah. So that's definitely something that would be a huge value.
What's the capacity of it? Of this?
Well, right back at you, if there's any way I can be helpful, I mean, we're really small in California, so these kind of like Washington things are not our normal thing, but I can never be helpful. I used to. I mean, I had
actual container has
not
to
quite
be
4 years here, both
created,
in
but
the house and then in the
container,
current administration, and that
it doesn't
was
require heat or water.
that was enough. I mean,
Excellent.
That's the kind of work I was doing.
You have a huge market.
Yeah.
I mean, there are institutions that would pay for that thing,
Yeah.
and camps.
Yeah, that's the idea.
You have a huge market all throughout Asia and Africa because the power goes down so often that if they had a sterilizer that didn't require electricity, this is huge.
Right. Right. Yeah, no, I mean, I think it's a really fascinating.
It's brilliant.
Yeah, potentially could be huge.
When I was here, and I love her. I mean, I think she's just she's so smart and she's dogged, and maybe I'm just lazy or impatient, probably both. I need
Excellent. It reminds me there's an
with
anesthesia
more immediate kind of gratification.
that
about what we're doing.
processes pure oxygen out of room air, and so you don't need the oxygen tanks, which are very expensive, dangerous, not to mention ridiculously heavy. And so you can just have the machine and you never need a tank again for oxygen. It reminds me of that. It's kind of magical and fabulous and portable, and I think the oxygen tank's going to go out of business for anesthesia. Why would anywhere? Why even here? Why would we want an oxygen tank if we can use something that pulls it out of room air? Gives you pure oxygen. Fantastic. Same idea. I like it a lot.
Do you have like a card or something that I can?
Right now I do not have a card, but if you have your phone, I can give you my email. You can just put it right in there. I'm going to Japan with no business cards. I can't even.
God, you were just everywhere. That's amazing.
Okay, so the real.
But what happened was I switched institutions, so I can't really use my old cards. And but I haven't started there yet technically, so they haven't made me any cards. In the meantime, I was thinking, I need to go on what is that website? Make myself some quick cards.
Oh, the ones that was advertisements about you get like 10 free Vistaprint.
Vistaprint. I love Vistaprint. I even have an account. And I've been so crazy, I haven't even gone to Vistaprint. And I'm going to Japan with no business cards, which is bad. Poor form. It's too late. Anyway, LJ Ramanzi, which is ROMAN. Okay, got it? LJ Ramanzi at
Like you're
Gmail.
looking at the colleges, particularly.
Fantastic. Yeah, I think our CEO is Dr. Jim Bernstein. I'm sure he'd be really interested.
Yeah, so when they're at that point, you're farther along and you're looking for distribution, I can give you some connections.
Wonderful.
Far out of the
I mean,
mainstream.
it doesn't need promotion. Seriously, that's just brilliant. What? What's wrong? What?
We were just having a candid girlfriend conversation. I mean, not about boys or anything like that candid, but I was wondering if the mics were picking it all up.
Oh.
Webcasts.
I have no
think
idea.
they cut that kind of stuff off for the webcast. We'll add it in the event write-up, though.
Well, it was a political discussion. It was a very candid one.
Oh, okay.
Amongst colleagues. Who do we talk to make sure that that's, I mean,
Yeah, that won't pick up. Okay. They cut it off once people.
Okay, okay. Yeah, would you? Thank you. You know what I mean? Hi.
How are you?
Well, I don't, I've had like a week that started with, 2 a.m. in a New York hotel room. I mean, I could have been here, I went to New York, got in late Sunday night, and I've just been rocking and rolling with Johnson and
Did you come
Johnson's
down from New
announcement.
York?
Yeah, yesterday on the train, and then met with, that's what I was talking about Dolores staff person today about this stupid Lewis Wall bill. Remember the bill? Did you see it? U.S. Centers of Excellence for Fistula.
I thought that was killed. Are you
Lewis-
fucking kidding me?
No,
It's
I'm
a
not.
bill?
Oh yeah, it's a bill. It's a bill. And actually, Christoph mentioned it.
Please,
I
please
know.
make that go away.
Well, that's what I'm trying to do.
That is so bad.
Actually,
Please make it go away.
well, I actually mentioned you. See, I dropped names whenever I can. Well, what I was trying to do was like, okay.
You are meeting a celebrity.